We've got about an hour together, I believe, so a fair bit of time, and there's probably 4 key things I want to cover today. The first thing is to outline why interventions for family caregivers are necessary in terms of trying to reduce the psychological burden of being a carer. Secondly, to provide you with an overview, it's very much an overview of a randomised controlled trial that we recently completed. And then thirdly, to discuss some of the challenges that arose from that randomised controlled trial and some other research that we've embarked upon over several years. And finally, not to leave you with challenges, but talk about perhaps some strategies to overcome some of those challenges. So a fair bit to cover, but so we have got a fair bit of time together. So it's a fairly sort of intimate room, so I'm happy for this to be rather than a didactic lecture. I have got quite a few slides, but I don't want it to be death by PowerPoint, so we'll take some pauses in between. I'm happy to take questions as we go, so if there's things you want me to clarify, please just don't hesitate to put up your hand and seek some clarification or ask a question. Just out of interest, how many of you are currently involved in undertaking research with family caregivers? For those of you who have undertaken research with family caregivers in the past, and those of you who might be contemplating it if you haven't embarked upon it before. Thank you. Thanks very much. Okay, so as I said, I'd like to start with some reasons as to why I think it's pertinent that we should conduct studies to try and prevent poor psychosocial outcomes for family carers. The first reason is fairly simple in the context of palliative care. The World Health Organisation definition makes it quite explicit that we should be looking after family carers as well as patients whilst they're looking after their relative or friend, but also during the bereavement phase as well. So we've got an obligation to look after family carers. And certainly the standards of palliative care provision in many countries of the world are quite clear about that as well, that there's expectations that healthcare professionals try and meet the unmet needs of family caregivers. So this is core to our work in palliative care. It's not a nice little extra that we might think we're doing out of the goodness of our hearts. This is something we should be doing, and we should be embarking on strategies to support carers. We also know through a number of studies that many carers have unmet needs, despite reasonably good quality palliative care in many parts of the world. Many carers actually say, well, look, I really missed out on this, that and the other. There's some gaps here in service provision, so we need to do more. We know that many family caregivers too, within the context of home-based palliative care in particular, are involved in complex tasks. So many family caregivers might be administering morphine, managing syringe drivers, etc., etc. And for us as healthcare professionals, delivering those types of medications for the first time, well, certainly my circumstance was quite anxiety-provoking. That was in a safe environment of a hospital. So imagine giving morphine to a relative at home, perhaps for the first time. So carers need guidance and support to help them with some of these complex things. I think it's important to note that for some family caregivers, they will really struggle with this experience, but we don't want to pathologise caregiving. So as I said, some caregivers will struggle, but many will actually do okay in the scheme of things. But nonetheless, there is a proportion that will find this extremely challenging from a psychological perspective and from a social perspective, so we do need to cater for that cohort. Certainly in Australia, for many family caregivers, it's their first experience in looking after someone who's dying. Most people in Australia would have only seen a dead body or a dying person on television, so they have misconceptions about what dying means and what it might mean to look after someone as they're approaching death. We know too that a number of reviews have shown this, that most people would like to be cared for at home. Many people would like to in fact die at home, but one of the primary reasons for that not being able to be achieved is usually through lack of support for their primary family caregiver. So it makes sense if we can prepare the family caregiver, look after them a little bit better and support them, the chances of the patient's wish to be at home has a greater likelihood of being fulfilled. There have been several systematic reviews now. The Cochrane review done a couple of years ago. There's been a few other reviews in recent years which show quite clearly that there is a lack of evidence-based strategies to support family carers in the context of palliative care. We know too that for healthcare professionals, many find this type of support very difficult. It's not uncommon to hear healthcare professionals say, it's hard enough looking after the patient, let alone their family. And some healthcare professionals actually say, the patient's easy, the family's a nightmare. So how do we design, or we need to design therefore interventions that can work in a pragmatic situation, that are resourceable and can actually be readily implemented into practice. And the final reason I've got there is perhaps the most simple, insofar as logical. It makes sense if we support families that for many patients they'll actually feel better about contemplating their own death as well. So as for many of you in the room who are involved in palliative care, I'm sure will agree that some patients, in fact many patients, can actually deal with death and dying in a reasonably okay manner, but often worry about the burden they're placing on their family, or if their family's not being well supported. So it follows, therefore, support the family, and for many patients, their lead up to their death may be less burdensome. So hopefully I've convinced you that we should be embarking upon these types of strategies. Are there any questions about those reasons that resonate with people? Okay, thank you. So I'll move on then to give you an overview of a recent randomised controlled trial we've conducted, and it really is an overview. It's a summary, and for those people who want more information, there's a couple of references that I'll put up on the slideshow, and also you can contact me obviously if you want more details. So the trial that I'm referring to stems from this pilot randomised controlled trial that we embarked upon about 10 years ago, and this was undertaken for pretty much the reasons that I outlined on the previous slide. And this trial was underpinned by interviews and focus groups with current carers and bereaved carers to hear from them what they would want to have in terms of the ingredients for better support in the context of palliative care. And that was coupled with a systematic review. So that helped inform the ingredients of the intervention, I suppose. And that was checked out with healthcare professionals in terms of utility of the intervention, and then this pilot randomised controlled trial, which I think involved about 120 caregivers or so. And so the lessons we learned from that was that, one, we needed a bigger sample size. Two, we needed to modify the intervention in terms of the dose and some of the ingredients of the intervention. And very much in keeping with the MRC framework of complex interventions, the next stage from this was to actually undertake a much larger phase 3 trial. So the design, as I said, was a phase 3 pragmatic randomised controlled trial, 3-arm, and I'll explain why the 3 arms in a minute or two. 3 data collection points. So the first one was baseline, so caregivers were recruited as soon as possible after referral to specialist palliative care service provision at home, and then 2 weeks after the intervention, and the intervention lasted for about 3 or 4 weeks. And then the final data collection point was about 2 months after the patient had died. And our hypotheses were as follows. Our primary outcome, what we were most interested in, was whether or not this intervention could actually reduce the psychological distress of primary family carers at time 2 and at time 3. But related to this, we also wanted to reduce carers' unmet needs, increase their sense of preparedness for the role, because that was what we were continually being advised by carers, and indeed in the literature, that many family caregivers feel unprepared for this role, looking after someone who's dying. They often feel thrown into the experience without a great deal of insight. We wanted to increase their sense of competence and try and make the experience a little bit more rewarding. But those particular outcomes were explored only at time 2, because that was obviously the period of time when the carer was actually looking after the patient. So they weren't relevant, obviously, for time 3. And we use mixed model, repeated measures and intention to treat analysis to deal with missing data. So any questions on the design? I'll go into a bit more detail about the intervention.
What do you mean by mixed model?
That's a very good question. It's a new technique, rather novel technique, and it has created a lot of controversy with the reviewers of the journal with whom we're trying to publish this data. Our statistician that we had involved in the study actually had to outsource to another consultant to get some detail about how to actually undertake the analysis. So it's too complex for me to actually explain, Sam, I'll be honest with you. It's some new novel way of dealing with data of this ilk. I'm sorry I can't be more.
No, just was unfamiliar with the term.
Peter, when you say pragmatic RCT, what is the pragmatic aspect?
Yeah, so the distinction is between pragmatic randomised controlled trial and an efficacy trial. So an efficacy trial would be a trial that's undertaken by perfect, so-called perfect conditions. But a pragmatic trial is very much that. It recognises this is a complex intervention and hence labelled a pragmatic randomised controlled trial. It's not a term that we've used. We haven't made this up. It's out there.
You just do it in the norm. You just trial in the normal circumstances as opposed to setting up this big fancy closer.
So the intervention, so it was a psychoeducational intervention, and the ingredients were very much in keeping with, as I mentioned earlier, in terms of our data we collected from family caregivers and also from literature. So for many family carers, they're not really familiar with what palliative care is and what it isn't. They often have misconceptions. So it was kind of step one to try and demystify what palliative care was. What are the typical kind of requirements or implications of being a carer to someone who's dying? How do I look after myself as well as a relative? And importantly, preparation for imminent death and bereavement. So as you all know well, for many family carers, particularly in home-based palliative care, they're often the ones that pick up the signs that their relative may be getting close to death. And that was an issue for many carers. They wanted that kind of information about how do they recognise the signs that death might be on the horizon. And that was supported by a guidebook and also a specific care plan that was developed with the palliative care team to try and support the family carer. So the study was conducted in Australia, in 3 states of Australia, New South Wales, Victoria and Western Australia. And we targeted the primary family carer of patients with advanced cancer. It was delivered by a palliative care nurse. And there were 2 versions of the intervention. The intervention was the same, apart from the fact that one of the interventions comprised 2 face-to-face visits, and the other intervention was one face-to-face visit only. And they're also augmented with phone calls as well. The rationale for that was that really around the resource implications of an intervention this ilk, we wanted to try and discern whether or not one visit was as good as 2 visits, and that particularly in a country like Australia with its large landscape, it's very much helps in terms of implementation if we know whether we need to support a 1 visit or a 2 visit intervention. So that was the rationale for that. So, and we compared that to standard specialist palliative care provision. Is that clear? Does that make sense? Okay. So this might be hard for people to read at the back. I won't go into the detail, and I don't have time to go into sort of socio-demographic details of the study, but in short, there was 150 participants allocated to control and 148 to control and 150 to intervention, and they were split. So what did we find? So at time 1, baseline, so upon very soon after referral to specialist palliative care, across all 3 arms, the rate of psychosocial distress, psychological distress rather, was about 50%, and that's as measured by the General Health Questionnaire, which is a tool which is fairly commonly used in the UK, I think. At time 2, there was no significant decrease in unmet needs, distress, and there wasn't a significant increase in positive emotions. However, there was a significant increase in carers' sense of preparedness for their role and their sense of competence for their role. And not surprisingly, this was for the 2 intervention visit, but not the 1 intervention visit. So there's 2 opportunities to engage with a healthcare professional, talk about being better prepared, being more competent, etc. So it made sense to us that the 2 visit version had more potency than the 1 visit version. So no impact on psychological distress at time 2. However, in time 3 there was. So the intervention, both intervention groups did better in terms of bereavement compared to the control group. And if you look at that graphically, it makes it a bit clearer. So the blue line there is control. So you can see here that's post time 2. The distress scores go up. For the 2 visit version of intervention, they go up. But the 1 visit version, they kind of level off, or certainly don't increase as much as the control group. So for time 3, for psychological stress, the 1 visit version intervention did better than the 2 visit version, which was counterintuitive. So is that clear to people? Because it was certainly confusing to us. So for time 2, the 2 visit version seemed to have an effect on preparedness and competence. And at time 3, we had an effect on psychological distress, but for the 1 visit version only. So I'm really perplexed.
I'm not looking, well, it's the counterintuitive nature of it. And I mean, you normally think like washout would mean that if there was an effect on distress, it should be at time 2, and then that would get less over time. Did you come up with any hypothesis as to why?
Well, there is a bit of literature around the benefit of face-to-face, the benefit of telephone over face-to-face. So, as I said, for both intervention groups, part of the intervention was a telephone call as well, interspersed between the visits for the 2 visit version, and 2 phone calls for the 1 visit version. So, for some people, we can speculate that as caregivers, they have more control over that phone call. They could actually end the conversation. Whereas if somebody actually comes to your home as a caregiver, many of you will be familiar with this, you kind of feel obliged to feed and water the nurse or healthcare professional who comes in and shows some family photos, etc., etc. You're almost entertaining sometimes the healthcare professionals coming to the home. So whether or not it gave them an opportunity to have more control via phone rather than face-to-face could be the case. But there is some research that suggests that telephone-based interventions, or indeed online interventions, are just as good as face-to-face.
Here I'm just wondering, like in terms of your sample size in time 2 versus time 1, or sorry, I guess treatment 1 versus treatment 2, is like with respect to your escalation and distress scores, did you have some outliers that really sort of had some extraneous event that really sort of drove up the numbers there?
My understanding is that was dealt with. So
okay.
That's the kind of the party line, is that? So, in terms of the conclusions from the study, significant increase in families' carers' sense of preparedness and competence for the role. The intervention mitigates a rise in distress, but doesn't prevent it, and that's that would be hard to prevent in all distress. A number of limitations with this study. Problems with attrition, selection bias. So we were only getting those caregivers who could speak and understand English. Usually the caregivers that come into these studies are potentially the more highly functioning caregivers. And the future work we need to consider is why the 1 visit was more potent than the 2 visit in terms of psychological distress, and look at other ways of perhaps delivering this particular intervention and obviously to other populations outside advanced cancer.
Is there a significant difference between 1 and 2? I mean, 1 visit and 2 visit at the end, as well as between 1 and 3 and 2 and 3? Go back. Yeah, like between the green and the red, that was significant as well as between.
Sorry, jet lag is kicking in now.
Yeah.
So do you explain?
Just was the difference between the one visit and the two visits.
Yep.
That was significant as well. Yeah.
Yep,
It is.
yep,
Okay.
yep.
I confused myself, I think.
That's right.
And sorry, Peter, across the GHQs, 12 school, 12, isn't that right? 12 items?
There's a 12,
I suppose there are
36
lots,
and there's
yeah.
a,
Which one did you have? Or
it was the 12 item.
The 12, right, yeah, very usable. And then is that the difference there? Presumably that's judged as clinically significant, but it looks like it's potentially quite a small difference across groups. Would that be fair?
Well, it's a good question in terms of determining the clinical significance of the GHQ. Was something we tried to find out at the time in terms of lead up to the study. We're using it again in another trial as we speak, and we can't find decent data on it, certainly in the context of family carers. So I think it's a kind of eternal question for many studies of this ilk, what is a clinically meaningful difference? So we haven't been able to find anything on the GHQ.
And then, now probably going into questions that you never will answer, but did you get qualitative feedback from your carers that would help you to interpret the numbers?
We didn't, no.
It's hard to fund that sort of thing.
Yeah.
Is it possible, Peter, that some of the carers would have found it too much having just one visit with all this information? Presumably there would have been written information, maybe a DVD, I don't know, and then discussion with the family carer. It just seems an awful lot to give somebody one visit.
Yep.
But maybe for some people that worked and that was what they wanted.
That's a good point, actually. So it was the way it worked in terms of the intervention. So what would happen is the caregivers were sent out a guidebook and they were asked to read in advance of the visit certain sections of the guidebook. So the intent was that they had some preparation and also to note down any questions they might have about the caregiving role. So it was structured in that way. And then thereafter, following the first visit for the two-visit group, there was tasks set, several tasks for the next visit or the next contact that related to the structured intervention. So it was set out in a way that was intended to be digestible to small chunks. Yeah, but it's a good point nonetheless.
Maybe that, I'm sure you considered, would that have added pressure, or is something that they were supposed to achieve by their second visit, would that add pressure, and then maybe that's what will determine negative, positive.
Could be. I mean, it was done in a way that was, it was quite diplomatic. It wasn't sort of like, do your homework, otherwise you'd be in trouble. It was kind of, it was kind of like, if you've got time, it might be helpful. Other carers have found it helpful to read up on, typical signs that your relative may be getting worse. Yeah, it's directly. So, for those reasons, the time 2 data is written up in this particular journal. And we're just trying to get the time 3 data published, as I said before. Okay, any questions about the trial before I move on to some of the challenges, some of which we've alluded to?
I guess recruitment is one of the big questions that people ask
Sure.
about with the trial, and it looks like you had to do a lot of groundwork as always. But would you want to say anything about that, or how did your researchers find that?
It was, look, one of the biggest challenges, and it's, I mean, the recommendations are always that, if you want a large sample, ideally go to multiple sites, but with multiple sites comes, from my perspective, multiple headaches. In terms of managing numbers of staff, you'll have, like in any kind of team event, I suppose, or pursuit, you have some people that are passengers. And we certainly found that on this particular study. We had a big team across 3 states of Australia, and there were some people who really performed well in terms of being really good at recruiting, and others who kind of dropped the ball. So that was challenging. From a a practical level too was and frustrating perspective was different perspectives of the ethical boards. So in 2 states, it was okay for us to go directly to the carer, and 1 state, the ethical board said that we actually had to go via the patient to get to the carer. So that complicated things. So for some patients, they actually said, no, I don't want my relative being involved in the study, for example. So that's a little bit difficult.
This was just directly to the caregiver, the patient would have been involved at all,
Your intervention didn't really involve the patient.
No, and the rationale for that was in our pilot work. So 95% of the carers in our pilot work actually chose to actually have this type of intervention alone, that is without their relative. And that was interesting because we had assumed that some caregivers would actually want to have it with their partner. However, in some respects it wasn't surprising, because for those of you involved in palliative care as healthcare professionals, this won't be a surprise to you, where perhaps in home care you go and see a patient and you have a chat to the family member at the same time, you think everything's fine, everything's okay, you've done your good assessment, etc., things are okay, and just as you're leaving, the caregiver kind of taps you on the shoulder and says, oh, have you got a minute or two, which ends up being about half an hour out of earshot of the patient. So, you know, for a lot of caregivers, they want that one-on-one time, and they actually don't necessarily want to convey their concerns in front of the patient, because they're worried about, you know, causing undue kind of worry for their relative.
And whenever you're in the situation of going via the patient compared to just going direct to the caregiver, I mean, were there any situations where you felt in retrospect, oh, that ethical requirement was good?
No, I think I'm a proponent of being able to go straight to the carer. So the way we did that was, it pretty much was a letter from the director of the palliative care service that went out to all the caregivers who were on the program, so to speak, and it pretty much said, you know, our service is interested in quality improvement. We occasionally conduct research studies, and you may be approached by a researcher to explain the study to you, to see whether you might be interested in being involved, and that choice is completely voluntary. And I think that's a reasonable, but that's, you know, of course I wouldn't know. But going via the patient just adds an extra layer of complexity, and as I said, potentially they gatekeep against their relative being involved. So because it actually denies the carer an opportunity to be involved in research. So I'll move on then to the challenges, and I've kind of set this up in kind of a research kind of process way, if you will. So the first one was getting the funding, and some of these challenges are specific to family caregiver research, and some are just, you know, for the general hard luck stories of research. Most of the family caregiver related, and it seems to me this situation is similar in the UK. That it is actually hard to find funding for studies like this. That being so, and the same situation is occurring in Australia. So we were fortunate in terms of the pilot work that there was the pilot work was funded by a scholarship, and this particular study was funded out of priority-driven call by a National Health and Medical Research Council. So I think we were lucky. But there's not a long history of family caregiver research, certainly in Australia. So, you know, this is not something that attracts a lot of dollars. We're trying to ascertain the Australian data, but my understanding is in the UK and the US that and this is just general palliative care research, the palliative care research attracts less than 1% of the cancer research dollar, yet, you know, 1 in 2, 1 in 3 people with cancer will die of cancer. Yet we're only getting less than 1% of the research dollar. I mean, it's illogical. And also too, around the funding and trying to win grants is actually establishing a team who's got a track record in family caregiver research. So we had, a good team. There was some good people on it, but not all of them had experience in conducting research or embarking on interventions with family carers. So this is still somewhat novel territory in Australia anyway. So in terms of moving on to the design of the intervention, from a practical perspective, this intervention needed to be short. Okay. The average length of stay on an Australian palliative care home-based program is about 5 months, and in an inpatient facility it's about 21 days. So it's not a lot of time to actually recruit people to study, offer the intervention, etc., follow up with longer-term data collection. We were unsure about whether or not to screen or not for this intervention. So, the point being, the question being, should we actually discern those caregivers that actually confronted with quite severe psychological distress and only recruit those to the intervention? We decided not to. We thought that pretty much if this is going to be a practical intervention, most caregivers we think need this type of information or preparation for the role, etc. And then about 40 to 50% on screening measures meet the criteria for psychological distress, then we should invite everyone into the intervention. That was our thinking, and it may be some people may differ in relation to that. And then the query of which carer. So often, as you know, many patients have multiple carers involved. And ideally, we don't think we should be waiting to this point to offer an intervention of this ilk. It should be earlier in the disease trajectory. But from a practical perspective, we couldn't do that. We couldn't recruit people to a study of this ilk if their patient wasn't already considered palliative. And then this sort of ongoing saga of what should be the primary outcome. As you saw in terms of we had psychological distress. There's a number of different considerations within or endpoints within our intervention. It was multimodal. We're looking at preparedness and unmet needs and so forth. So it was a bit of a toss of the coin in terms of should it be unmet needs or should it be psychological distress. They're obviously related to a certain extent. In terms of ethics, and we've touched on this a bit already, about access to carers, and I'm mindful too that in some ethics committees they won't even allow you to collect data from bereaved carers. So this becomes very difficult in terms of, from a research perspective, if ethics committees are actually blocking the capacity to engage caregivers within research. And I think this gatekeeping occurs at a few levels. So one at kind of ethical or institutional level, it occurs too at healthcare professional levels. So we actually have healthcare professionals who gatekeep. So they might say, oh, look, Mary, there's a study going on, and you've got a lot on your plate at the moment. So if somebody rings you about this particular study, just you can easily just say that you're unable to assist in that regard. So it occurs at that level, and it occurs also between the patient and carer sometimes. In terms of recruitment, we've touched on that, but there's issues of selection bias, where, as I said, you're getting people who perhaps maybe the more highly functioning caregivers. We didn't have the funds to actually conduct this study with those people who couldn't speak or understand English. We've spoken about the issues around multiple sites. In terms of data collection, what is the most appropriate measures? A number of different, and this is an issue not just specific to family care research, but there's a number of different measures of distress. Which one do you use? It is a bit of a gamble, certainly from our experience. You do as best you can in terms of justifying it. And in terms of data collection, what's most optimal? Is it face-to-face? But there's resource implications for that. Or is it a question of sending it out in the mail, okay? Or should you do it by phone? And obviously depends on the data you're collecting. We had quite a bit of missing data, and by that I mean two things. One, some of the questionnaires weren't completely filled out in some instances, but also we have periods where people would actually do time 1 but wouldn't do time 2 but would do time 3. So this is where this complicated analysis system came into play, and also this approach of intention to treat, which deals with missing data of this ilk. And the problem with attrition, so we didn't want to recruit caregivers who were looking after someone who was imminently dying. So as part of our screening, we tried to screen out those people who were imminently dying, but that's not an exact science, as you all know. So invariably recruited quite a number of caregivers whose relative died within a few days, so we couldn't even deliver the intervention because their relative had died. The analysis, we had lots of different perspectives. I was on the ignorant assumption this is a clean randomised controlled trial. It's quantitative statistics. This should be, all no, it was rather complicated, and we had different perspectives about the best way to analyse the data. And dealing with the results, and again, this is not specific to family caregiver research, but we had this counterintuitive situation where the one visit seemed to be more potent than the two visit in terms of reducing or preventing poor psychological distress. And the final challenge, certainly I think for myself and others who are involved in this type of research, is trying to get it implemented. So we actually have had favourable results. You've conducted the intervention in a way you think is credible, insofar as you actually have perspectives of consumers, you have perspectives of healthcare professionals based on the solid lit review, etc., etc. You've done your trial, but yet who's going to fund the implementation? And this is a bit of a concern for us, not only for this one, but some other things we've embarked upon. I don't know, that's an issue for you guys. Is there sort of a system here that backs sort of credible interventions to try and foster their implementation?
There's a fund that the R&D office uses, a translation fund. You can get a supplementary grant to your primary research in order to fund how you're going to try and translate what you found academically into actually change your clinical practice.
That's great.
I don't know, has anybody used it? Carmel's used it, yeah.
But I mean, if you think well, that's great, but if you think even if you broaden this out from family caregiver research, I mean, trying to get some of the strategies to enhance palliative care provision into place, it's just so hard, certainly in Australia. I mean, it's just, we're competing with this kind of cure-focused society, healthcare professionals, and trying to get, palliative care implementation and knowledge transfer supported is a continual problem. Any other challenges that you guys, for those of you who embarked upon family care research, that you have that you want to share or that? Covered off most of them.
I just wonder sometimes if care fatigue can affect recruitment to palliative care studies. Do you find that?
Sure.
Yeah.
Probably in two scenarios. One is just in terms of they'd like to be involved in the study from the outset, but say, look, no offence to your study, but I've got too much on.
Exactly.
Or they actually come on to the study, they consent, and then time goes by and actually they've just got too much on. They can't complete the study of the data collection or complete the intervention. Absolutely.
Yeah.
And as you know, in palliative care, the situation changes so rapidly. The circumstances change so quickly.
Oh, can I talk about?
I'm really interested to know how you were able to define that a patient is in the palliative phase. Is that to do again with your clinic and the
That was actually,
setting?
yeah, so that's a plus actually in terms of, it was easy in this study because everybody was on a palliative care program. So everybody was receiving home-based specialist palliative care. So it was quite clear.
So it's clear.
Yeah. So
That's got to be tricky for a lot of studies that don't maybe have that structure in the health service that exists.
even still, however, for many caregivers, they were still a little bit perplexed as to what palliative care was. I mean, they were only relatively newly referred to specialist palliative care, but that made it a lot easier.
Peter, I know there have been discussions in the palliative care community about research design. And I remember a few years ago discussions around how RCTs were not suitable for palliative care because, in fact, a lot of RCTs failed to complete because of some of the issues which you're speaking to. And that sort of argument was a push to consider alternate methodologies to investigate some of the issues that are on the table with respect to serving this population. Just wondering, having broken your teeth through going through this, where do you, what's your view in terms of where the RCT fits?
Well, I'm across those perspectives, and I think that I think that blanket statement that RCT is inappropriate for palliative care is I don't support that.
Okay.
I think that where pertinent, embark upon a randomised controlled trial, but where pertinent, I think that would be the caveat. I think, and if it's not the most appropriate way forward, then work out one that is. I mean, we have to obviously think outside the square. But I've seen it published. People making those remarks. I've heard, over coffee at conferences, that we shouldn't be doing RCTs in palliative care. I don't support that.
I think one of the things I was going to say is the importance of doing a pragmatic one. Because basically, rather than having something, even if you could have something really tight and clinically nailed down, so you've got these people in a hospice there for a week while you're doing it or whatever. If you're doing it pragmatically, then you're more or less reflecting what the experience of a clinician afterwards will be. So all of those issues about I don't have time to be bothered with this intervention or this, with the thing. Those are exactly the things that clinicians will experience, and you're taking that into account. So if you're still getting the effect, even with all that noise around you, then clinicians can be more confident that, on average, it will still be worth doing it.
And I think, in many respects, we're playing the game. If we tried to get something funded recently where we actually went outside the square, and this was a cluster randomised controlled trial. We didn't proceed down that pathway. We actually modified it for issues I won't go into too detail. But it didn't get funded because the reviewers said we're not familiar with this approach. Why didn't we do the typical cluster randomised controlled trial? I think sometimes you've got to play the game. And also, if we want to get this stuff implemented, then this is the world in which we live, unfortunately. So it's that doesn't make it right necessarily, but it's a challenge. It's an issue.
I'm sure if you got through funding, you probably would have come up against the difficulties then in application. So, we're unfamiliar with this. What is this? This mysterious method of use?
Well, that's was Sam's question, which I tried to avoid around the analysis. I mean, this is what's holding the Time 3 paper up. I won't get into details about the journal, but it was good enough for the Time 2 paper, but doesn't seem to be good enough for the Time 3 paper. It's a fairly credible journal we're going with, and try to substantiate the approach in a number of ways. But all you need is one or two reviewers have been there bothered about something. It makes it hard to get it published. Okay, we've talked about lots of uplifting things around challenges, and you probably think, why should we embark upon research in the family caregivers? There's good reason to. So on to some strategies, and some of which we've alluded to. So these are just some things that have come out of not only this trial, but some other work that we've been involved with family caregivers. So we've spoken a little bit about this in terms of coming up with some different approaches to study design. So as you know, there's a lot of studies now using mixed methods or multiple methods, so that might be one way of trying to kind of unpack what happens within the study or intervention. I think, just going off from your point, Helen, about caregiver burden, minimising the time the carers may need to participate in the study or the intervention. So, these interventions do need to be short. I think planning for high attrition rates. So we didn't have high attrition, but we're getting kind of pool of data now, published data on what are some typical kind of attrition rates. So hopefully in the future people will be better prepared for what might those rates be. And Irene Higginson and colleagues have published in the last couple of years, just following on from your query, Kevin, around alternative approaches. So these are still RCTs, but these fast track and delayed RCTs. I'm not familiar with them. I don't know from what he is, but she published something, I think it was last year, within the context of palliative care. Apparently they've used them with other health groups, but she tried them within the context of palliative care, I think with a motor neurone disease cohort actually. And although I was kind of saying how hard it is having multiple sites, the reality is if you want big numbers for a big study, you need multiple sites. So you need to have those clinical relationships and as you know, those clinical sites often have to provide a lot of in-kind support as well. So making those friends with those your colleagues in clinical and allowing plenty of time for recruitment, given the recruitment problems we outlined. The opt-out strategy, and this may not fly with many ethics committees, but it worked for us in a couple of instances where pretty much the letter went out to the caregiver to say, we've got a study going on, unless we hear to the contrary, a research assistant will be contacting you. So that has helped us in a couple of studies, so it means we can approach the caregiver directly, but that may not fly with your ethics committees. And I think starting small, so if you're thinking about an intervention, actually going back to from a very pragmatic perspective, asking the care, the people who are going to actually be receiving these in the future, what do they want? What would work in practice? And the people who are going to be delivering it. So importantly, the healthcare professionals. This is the intervention that we've designed. Does it make sense? If this was going to prove effective, would you be able to implement it in practice with the right resources? I think I've seen on multiple occasions great interventions and showing great effects, but rarely implemented. And often it's, you talk to healthcare professionals and say, why? It's had great results. I say, well, there's no way we'll be able to resource implementing that. And it's just not going to work in practice, even if we have the funds. It's not sustainable. We can't do it. So I think starting off with the design intervention involving the people who are going to be involved in receiving and delivering it. And I think having a good theoretical framework is important. So I know there's criticism of the MRC framework by some, but I think that conceptually it does make some sense. Start off, do some pilot work, trial your RCT or whatever design you're going to have, and then move forward, rather than aiming upon this big multi-site study right from the outset. And I think being clear about the focus of the intervention. So some people will say, oh, we do this intervention. Well, what is it with caregivers? Is it a social intervention? Is it a psychoeducational intervention? Being quite clear. I know sometimes they're related, but being quite clear about the intent of the intervention. And considering whether or not one-on-one interventions are better than group. So we've kind of dabbled in both, and I think there is a place for both. I think we can't have a one-size-fits-all kind of strategy for supporting family carers. For some carers, the one-on-one intervention is going to work better than a group. For some carers, it could be really worse than going to a group session. And for some carers, as you know, won't want to leave the home. So even if they did want to go to a group intervention, they just don't feel comfortable leaving the home. And I spoke a bit about our individuals. It's pretty much multimodal, and that probably goes against the grain of pure scientists who say don't go multimodal. You really need to have a clear focus, a clear endpoint. But that's in the world of palliative care, that's not always easy. And going back to the point I made earlier around testing the utility early on. Does this intervention, is it applicable? Is it affordable? And is it accessible? So in the real world, people actually come to us for intervention and so on. And you do need to have the resources, obviously, the funds for these types of interventions. With the gatekeeping, I think just anticipate, I think it's going to occur inevitably. I mentioned 3 levels of gatekeeping. I think probably at least one of those levels is going to be apparent in more circumstances, I would imagine. But I think there are some ways around it, and I think slowly, institutional ethics boards are getting a sense of palliative care research may actually be something that you can embark upon. It is ethically okay to do this type of research. There's still some that perhaps say that this population is too vulnerable. How dare we be interviewing and intervening with this group? But I think there's quite a few studies coming out now about the benefits that patients and carers have from being involved in this stage. I don't mean about the benefits of an intervention, but they're actually asked, was being involved in this research, burdensome for you, was it beneficial, etc. and there are some studies coming out for both patients and families that are showing that it's not necessarily burdensome, so that can help in terms of changing attitudes of ethics review cadres. And I think, I mentioned about multi-site research and involving clinical partners, so I'd advocate actually having clinical partners on research grants where pertinent, and whether or not they're at AI level or CI level, depends obviously on the situation, but that's something that's benefited us in terms of establishing those relationships, maintaining those relationships, and they certainly benefit and value the feedback. And related to feedback, we've found too that some clinical sites feel like they're a bit used and abused as pretty much factories for research. It's just our experience with some of these studies. We feel like they got in touch with us, asked us to be involved in the study. We didn't really hear about the results of it. So I'd strongly encourage you to actually continue to update the clinical site that you're working with in terms of what's happening with the study, and most importantly the outcomes of the study, because often you may not get the work published for several years afterwards, but you can at least give them a summary of the results, and then ideally once you get it published let them know. So in terms of some general strategies, well, I think unfortunately in palliative care, certainly in Australia, there's not a consumer group for palliative care, and that for many people that seems obvious as to why there isn't one, but I think that perhaps there could be. If you think in other areas of oncology care, for example, certainly in Australia, the breast cancer group, consumer groups are extremely vocal, but we don't have a consumer group in palliative care, certainly in Australia, so there's no sort of voice to advocate for research funding. And we need to be able to influence policy and increasing the funding opportunities. And I think changing the attitudes, again, unfortunately in Australia there's a lot of people who don't know what palliative care is. I think the situation's a little different in the UK, is my suspicion, with kind of the hospices in many, the charity shops in many of the towns and so forth. I would assume, correct me if I'm wrong, that a lot of people know what hospice care is, but certainly in Australia a lot of people don't know what palliative care is. And then finally, a bit of a plug for the importance of working together, and that was the rationale for the inception of the International Palliative Care Family Care Research Collaborative, which is very much really a special interest group. So this is run, it's auspiced by the European Association of Palliative Care, provide us usually with an opportunity to meet at their conference, their annual conference. So if any of you are interested, this is really starting to take shape. We're going to have a forum, electronic forum soon, where people can actually connect if you're a member. So if you've got a query about which tool or how do people go with collecting data on such and such, they can actually communicate with one another through resources that have been developed. So please, if you're interested in becoming part of that, we encourage you to go on to that particular site.